it is due to antibiotic resistance, but then it's also due to research and all kinds of other host of reasons why, and we'll kind of go through that here in a minute. And I didn't get a chance to do lecture objectives, and so I will do that for this lecture. And I'll send it to you out because there's a lot on here. As I was trying to make them last night, I was like, oh my God, I don't even know where to stop, start. So these are just talking about trends in infectious diseases in the last, I guess, 20th century. So a lot of times we've seen a reduction in certain diseases because of advents of vaccinations.
There's an error on there. I was like, it's not tornadoes, it's right. I was like,
It's weird that like the whole room is like
Gutter flooding, so Amber alert.
At least you know it's sufficient.
Yeah.
You didn't get it. You have to have it turned on.
I don't think I have this. I don't get it.
Maybe it's because
Got it like 4 hours later. Like I heard about it on Twitter and people making fun of it.
Okay, so other reasons why is areas are getting cleaner, antibiotics, vaccinations, and these all are reasons why we're having decreased morbidity and mortality in the Western countries. Eastern countries are a little bit different because they still have the same issues that they've always had. So since the last quarter of the 20th century, we've seen some resurgence or emergence of newer diseases or diseases that were once eradicated or not as common to where they would become pandemic or epidemic diseases. So on this list here are HIV, even that's even better now than it used to be. Lyme disease, then hepatitis C is on the rise, as well as some of those STDs that we talked about when we were back in women's health is gonorrhea, chlamydia. All of those are back resurging because of a lot of several factors. We already talked about then too is education. You know, the United States doesn't want to spend money on preventative measures, and I think that's a big issue. Is they'll pay lots of money to learn how to treat diseases, but preventing them is an issue. So again, this is just the definition of re-emergent infections, which we kind of already talked about. And this is a list. So this is not an all-inclusive list, but these are just a few ones that we're going to talk about. Pertussis. So pertussis made a big resurgence in the last few years just because of lack of immunizations. And I remember when I was pregnant, they made sure that my mother-in-law, my husband, everyone got a booster or was vaccinated. And then yellow fever. Again, that's from, we'll talk about that disease here today, but resistance to insecticides for those mosquitoes and things like that. They're just a lot stronger bugs than they used to be. And then the emergent infectious diseases like we talked about that are new or identified diseases and bacteria that we've never heard of before. And that's just due to research and urbanization and all that kinds of stuff that allows us to see new things. So infectious diseases worldwide, like we've already talked about, are major factors worldwide. 60 million deaths, 25 to 35% of 60 million deaths worldwide occur due to infectious diseases. And that's just kind of we talked about it. So there's factors contributing to these. Why? Why are things changing? Well, one is the agent. So looking at, we kind of talked about this earlier, was it? I don't know if I'll talk about this, but the evolution of the bugs itself. So viruses changing, mutating. So those are causes why some of these diseases are emerging. And then resistance to drugs we talked about, and then resistance of vectors to pesticides. So these normal, run-of-the-mill insecticides are not working against some of these different vectors. And then we talked about like influenza A. You know how sometimes, like last year, one of the strains wasn't working with any of the flu vaccinations, and so I think one of the hospitals had opened a whole new floor, or opened a floor up because of all the flu hospitalizations we're having, even though these people have been vaccinated. And then the host changing. So people moving to different areas, and then we talked about so like with Houston, the floodings in Houston, all those people having to be moved into certain areas, and then you have a higher population, everybody in together in a small space. And then you've got human behavior, so sexual behaviors of people not using proper contraception, condoms, that leads to emergence of diseases. And then the human susceptibility infection, so all the immunocompromised people, people with cancers, diabetes, those also put people at a higher risk of new diseases. And then poverty and social inequality, so that's always going to be an issue. Poor sanitation, poor access to care, those will always be reasons why we have emergence of disease. And then environment. So, who doesn't believe in global warming? Does anybody believe in it? I believe in it. I think Mother Nature's mad at everybody for us for polluting her air. And then just think about all the waters and rivers, banks that are, so low now that these animals move away because they can't find water resources. So then they move closer to humans. And so that's why we're more susceptible, because they like to come up and need to be fed. And you see all those videos now of bears and deers and alligators and all that in people's homes and stuff, which I would freak out if I were an alligator. Can you imagine going to your pool and seeing an alligator in your pool? But I guess that's a risk if you live in Florida or what's the other one that everybody Georgia. Is it Alabama?
They were in Georgia where I lived.
Yeah. I can't remember that.
Louisiana.
Louisiana, that's what I was thinking of. And then economic development and land use, so people, again, tearing down wooded areas, and all those deers and animals that usually live in those are having forced out of their homes. And then technology and industry, food processing and handling, so people not washing their hands before they handle your food. I saw this video recently. Did you see about that guy? And he worked at a ballpark in California, and he was making pizzas, and he videotaped himself spitting loogies in these people's pizzas. And then I don't know if he posted it or somebody posted it, but then he got arrested, and they tested him for, think about it, he could have all hosts of disease that are, they test for hepatitis, AIDS, HIV, and I think he can face up to 4 to 5 years in prison.
Did he have anything?
No, he didn't have anything. But can you imagine? Oh, it was horrible watching that video. But you never know, and so be always nice to your waiters and waitresses at restaurants. And then international travel and commerce. So people travel a lot more unique places to travel. With the advent of the internet, everybody makes everything look beautiful, and everybody wants to go and travel, right? So going to travel, coming back, bringing things with you, that's a big problem here in the United States. And then we already talked about regular public health measures, overcrowding, and then we already talked about surveillance system, lack of political will. So not using the funded money, federal funds to help prevent some of these communicable diseases. And then we kind of already talked about this transmission of infectious agents from animals to humans. So most of these emergent diseases are from either animals, wild or domestic. So with the avian flu and all that, and the swine flu, different pigs, chickens. So vaccinations of animals aren't as, well, I don't know if it's as, when you do shows, do you have to vaccinate all your animals, Casey?
Oh yeah, but you have to have like a vet look at them before the show, and then if they're slaughter animals, they have to check them before slaughter to make sure that if you gave them an antibiotic or something, it's not in their meat.
So then I don't know if, people don't do antibiotics, those rage-free animals, and so I don't know if some people are getting sick even though they're supposed to be organic, just spreading the disease that way. I'm not sure about that. And then again, humans getting closer to deer hunters, people hunting, they're getting out into the environment, they're putting themselves at risk by getting hit by us. And I already talked about the climate and environmental changes. El Nino, all of those big not monsoon, but hurricanes. And what's the one in Indonesia not too long ago? Tsunamis. So those, imagine all that water and all the debris and all the dirty waters. Think about how much disease that is carried out in those waters. We kind of already talked about poverty, poor sanitation, lack of funding. Like I said, we don't spend a lot of money on preventative medicine, but we spend a lot on treating them. Because in medicine, that's what you do, right? You treat diseases. But it's very hard to get people to prevent the diseases. I already talked about overcrowding. Has anybody been to New York? So you feel the crowd when you're out in New York City. Has anybody been to China? So my mom went to New York City. She liked it okay, but she thought it was too many people. She went to China. She hated it even worse. I mean, it was so overpopulated, like you're just walking around like this, 10 times as worse as you are in Manhattan. And she was just so glad to get back to Oklahoma where people keep their space, But that's why I think China implemented the one-child, theories are the one child is because not only they're being female, but I think it's the overcrowding, the overpopulation in China. And so I think that's why a lot of the diseases are rampant in Southeast Asia and the Asian countries. And then we already talked about this, human behavior, unsafe sexual practices, not washing your hands, people are outdoors a lot more, just being amongst people, especially if they're respiratory or aerosolized diseases that's easy to catch, not washing our hands. And then the antimicrobial drug resistance. So like she talked about yesterday, overprescribing. I was looking at something where Oklahoma, I think it was on the CDC, Oklahoma was one of the states that were ranked high in overprescribing. And I think a lot of it is when you go to urgent care, you want to go there, you want to get better, and you want that prescription. So a lot of times providers will do that just to get them out of their urgent care. They feel bad. But again, it's our job to educate our patients to say you really don't need this, because then when you really do need it, it's not going to work for you. So if you explain it, and I do that here a lot at the health clinic, because a lot of students, they're really sick, they're really congested, and they think an antibiotic's going to help them. But 95% of the time it's a virus. So if you explain it to them, tell them things that they can do to help their symptoms, then they're usually okay with it. And then non-adherence by patients, like she talked about yesterday, not finishing out the antibiotics, which again, I've been guilty of that in the past. And then counterfeit drugs. So people going down to Mexico, going to Canada to get drugs that you don't even know what you're taking, because it's less expensive. And then the loss of effectiveness in some of the bacteria. So community-acquired, pneumococcal, and hospital-acquired infections, antivirals. So, but I feel like the antivirals are better than they used to be. And then, so what's the consequence of having drug resistance is prolonged hospital stays. People are getting sicker quicker and people are dying. And so that's a lot more money, taking care of someone in the hospital, especially if they die, if they're there for 2 weeks. Kind of like you talked about with that infusion, it's $3,000, but that's still less than keeping someone in the hospital for 4 days. So then it's higher healthcare costs. And so this is just a picture of examples of emerging diseases. So I think the red ones are newly emerging, the bluish ones are re-emerging, and then the black one is deliberately emerging. So the one that's there is anthrax. So we'll kind of go into some of these diseases that are they emerging or are they being deliberately emerged? And we kind of talk about a few of them that can be used as bioterrorism. So people can use this to cause pandemics and epidemics. Anthrax is the first one that we're going to talk about. So anthrax. It is a serious infection caused by a gram-positive rod-shaped bacteria known as Bacillus anthracis. So it can be found naturally in the soil and environment. It's usually ingested by cows, pigs, in the wild and around the world. So they can eat those spores, and then so what happens is we as humans can accidentally eat them as well by ingesting or eating food by a contaminated animal. And so this, though, anthrax can cause a severe illness in humans and animals both, but most of the times for animals, they don't usually get that severe disease, or they do, but they usually will do, I think Anthrax has a vaccination livestock. Do you vaccinate your animals for anthrax, or I guess it depends on if they're in an endemic area where spores are out in the environment, that they usually require yearly vaccinations for anthrax. I don't know if Oklahoma's or Texas is endemic for it. And so, you know, the spores can live out in the soil for a long time. Again, like we talked about with some of the other diseases, they have to have the exact right environment. So when they're ingested by the humans or the animals, that allows it to become the active form and cause illnesses in both animals and humans. So it kind of talks here about how they get into spores. So how do you get anthrax? You can get it several ways. You can inhale it, you can ingest it, or you can get it through a break in the skin. So it's very uncommon for people in the U.S. to get infected with anthrax. It's more common in developing countries where, you know, again, we don't have veterinary programs where you have to actually vaccinate the animals. So people are ingesting contaminated meat, or they're handling contaminated meat. There was a accidental outbreak in Russia. So they developed, I don't know if they developed it or they harvested spores of the anthrax in this medical lab in Russia. And so they leaked it, it accidentally got leaked. Someone left the cover open when they were supposed to be cleaning or unclogging one of the valves, and they didn't tell the supervisor. So when the next person came on the shift, they didn't realize that the cap was not still on it, so they turned the machines back on, and these spores went flying everywhere. And then people tried to say, or the Russians tried to say that it was from contaminated meat that they got it. Like 100 people died, and they said, some people who died, they said it's because the butchers handled the meat, you know, but because basically they didn't want to get in trouble for violating all those biologic weapons tax, I guess. And then it says, and then you have a lot of the hoaxes in the late 1990s for anthrax, which we kind of talked about. So this is how, again, how anthrax can be used as a biological weapon. We kind of talked about how it can either enter through the skin or through the inhalation or the GI tract. So, but the GI tract one and the inhalation are the most severe diseases. Cutaneous can be treated, and it's not as deadly if you treat it with antibiotics. But inhalation and GI are the more serious forms. And this just kind of talks about how anthrax, once it gets in there, it multiplies in the macrophages, and then it can develop two toxins, the edema toxin and the lethal toxin. And these are what causes tissue necrosis. If someone gets a cutaneous one, it causes edema. The edema one is more in the lungs, so when someone inhales it, you can get mediastinal swelling, and inflammation blocks the airway, because it invades the lymph nodes of the mediastinum. So if you're seeing somebody who has a cough, fever, and you do a chest x-ray and they have a lot of edema, and they have the risk factor for anthrax infection, is if they'll have mediastinal swelling, lymphadenopathy. And so then this is after 9/11. We kind of talked about this, where people were getting letters, you know, in the mail that were laced with anthrax. And 5 Americans were killed and 17 were sickened from it. I wrote a note here somewhere. I think they said that the majority of those were cutaneous infections, because those who were opening the mails, the letters, and then I think there were maybe a few that were inhalation, but I think 5 of them were cutaneous. Okay, we already talked about that. So the cutaneous one is the more common, but it's the more naturally, you know, form of anthrax, because if it's out in the soil, and if you're a worker out there, you can actually get inoculated with it. But if left untreated, the cutaneous one can lead to a more generalized infection that can be fatal. So they actually read that there's a fourth route of injection or infection of anthraxes by IV drug users. But it's only been found in Europe so far, because they're usually heroin addicts that are injecting with the needles, and the heroin has been made in countries where anthrax is endemic. That's why they're getting it in Europe. So what does one have if you have, someone might come in with a GI anthrax? So it's kind of, a lot of these diseases, especially in the fever-borne ones, they're all going to sound like a viral illness. You can have fever, you can be lethargic, abdominal pain, bloody diarrhea, and that sounds like what, colitis? It can sound like several things. But sometimes the people can start off with ulcers in their mouth and their esophagus. They get fever, lymphadenopathy, but this is after they eat poorly or contaminated cooked meat. So here, early antibiotic treatment is, it says it's undefined, the risk of death. And then cutaneous. So with these, you'll get a little papule where it's inoculated in the skin. Start off like a small little pink maculopapular lesion. And then it can get redder, become depressed, and you get this eschar, or this black little ulcerative area in there. But again, it is most treatable. So with antibiotics, risk of death is 1%. Without it, 20%. There's 4. So 4 of those, I guess there were 23 cases of anthrax in the letters from September to October 2001. 12 cases were cutaneous, 11 were inhalational. There were no deaths associated with the cutaneous cases and 5 deaths with the inhalation ones. So 6 people survived that inhalation one. So this is what a cutaneous anthrax, so it has that black scar, kind of gets a crater in it. It almost looks like a cigarette burn too, just or a cigar burn in the shape of it. And then the worst one, which is the inhalation type. So again, these people have a program or an illness that's kind of a viral, febrile illness. It's kind of hard to tell, differentiate from anything. Fever, fatigue. They usually don't have respiratory symptoms yet until they get the lymphadenopathy, the mediastinal lymphadenopathy. Then you get the shortness of breath, people may become hypoxic, and then if there's significant swelling, then that's when they start having respiratory distress, can lead to death. And then most of these people will develop a anthrax encephalitis, so they get the confusion, neck stiffness, headache. You'll see that in about 50% of the patients. So it's very important, to get history. But I mean, I was like, how would you ever know if someone came in with just a febrile viral illness? When would anthrax inhalation be on your differential? Unless there was cutaneous cases that came in of somebody having cutaneous anthrax, that it would be on my differential. But day to day, this would probably be on my lower differential. Someone came in with a viral illness. And then you can develop into the terminal phase where they get dyspneic, they get cyanotic, they get shocked, septic, with widespread disease, and that's when most of them end up dying. Usually within 24 hours, they say, if it gets to the terminal phase, they're usually dead in 24 hours. So how do you diagnose it? So if somebody comes in with sudden onset of respiratory distress, you get a chest x-ray and you see mediastinal widening. But it's not specific for that disease because you can have mediastinal widening with lymphomas, you know. So history is key. You can also do gram stain in culture. And then PCR and immunohistology testing. Bless you. Oh wait, was that Dan? Maybe I should bless you. Okay. So just remember, with anthrax, if they're inhalational, you want to remember your ABCs. So airway management is key for these patients. Treatment. So pretty much everyone will get antibiotics. Ciprofloxacin and doxy are usually the mainstay. You can give them an antitoxin and also a vaccination. And then post-exposure. So you think someone has been exposed to anthrax, or anybody that worked in one of those mail care, any of the mail flu people would have been prophylactically treated for that as well. And then there is an anthrax vaccination. It was FDA approved in 1970, but it was relicensed in 2008. And the vaccinations are usually only good against cutaneous and inhalational anthrax. And I think in your lecture thing, I may put 6 injections, but it's actually just 5. And to remain effective, the patient has to have yearly boosters. So who should get a vaccination? Not everyone should get an anthrax vaccination. It's those who could be exposed to large amounts of bacteria, those who work in the lab, maybe military personnel who work in bioterrorism, things like that, and those who handle animal or animal products in the endemic areas are those who should probably get them. And then Becky's going to really talk about this is the plague. So is there any, I remember parts of history about the plague, and then what show was it that they had? Was it in, was it Downton Abbey, or was it The Crown, where they talked about the plague? Did anybody watch either one of those? I mixed that up. Was it Downton? I remember there was something where, like the whole, like the whole city was like clouded with fog. Or was it the black fog? It was some fog where people were getting sick. But the history of the plague. So it's been been around for thousands of years. And it said it's been estimated that over time the plague has been responsible for over 200 million deaths, and as far back as 1320 BC. There have been several major pandemics, and then the Black Death in 1346, and then we're currently in what we would consider the modern pandemic that began in 1894. So again, the first two, the anthrax can be used, but so could the plague. You would think, okay, how would someone use the plague as bioterrorism? But actually, I think this one was, because this has a vector. So would you really use a vector, usually like fleas, rodent fleas, to cause a pandemic? I think back in the war in Japan, I think it was, they had some study where they had these poor people that were being inoculated with any disease that you could ever have. And I don't remember exactly why they were doing it, but they also found these rodent fleas, and they would have them bite these people and say that they were helping them when they were actually inoculated. It's kind of almost like that tzatziki. Tzatziki, isn't that a sauce? Okay, anyway, I digress. So the plague. So it affects human and other animals. It's caused by a bacteria, Yersinia pestis. Didn't you guys already talk about Yersinia and GI? And it's carried by rodent fleas, which causes primarily bubonic plague. So I guess let's see, the outbreak of rat associated plague occurred in Los Angeles from 1924 to 1925. And since then, the plague has occurred in rural and semi-rural areas of western U.S. where the types of rodents are found. So you can have bubonic plague. You can also, if you get in contact with contaminated fluid or tissue handling an animal, like a dead rat or that's infected, you can get septicemic plague. And then you can also get infected by respiratory droplets. So someone who has the plague and they cough on you, then you can develop pneumonic plague. So what does bubonic plague look like? So again, looks like a viral illness. So you do fever, myalgias, headache, chills. So usually it will occur about 3 to 5 days after you've been bit by a flea. So sometimes you can get just a small edema or swelling around the insect bite area. And then if, let's say, someone is bit in their leg, usually because the toxin is carried through the lymphatic system, so if it's bitten by the flea on their lower extremities, they will usually get lymphadenopathy in the groin. And if someone's bitten in their upper extremity, they'll usually get lymphadenopathy in the axilla. And these are referred to as buboes, lymphadenopathy buboes. So they're very swollen, painful lymph nodes. Usually cutaneous, you can have 25% of cases. If treated, you have a 5% mortality rate if it's treated, 60% if you don't treat it. So this is kind of a picture of a bubo. See that poor little kid? You see it right there underneath his arm, his right axilla? And then that's the right groin. And then pneumonic plague, same thing. They can start with a kind of a viral illness, high fever, chills, body aches. With these people, though, they usually always will have cough or plague syndrome. And usually that occurred within 24 hours. So these people get sicker quicker. I know it says the incubation day is about 2 to 3 days after being in contact usually with someone who has had the plague. And then these people can eventually develop pneumonia. So they'll have patchy infiltrates on x-rays. So again, it's the most serious form, and it's the only form of plague that's transmitted person to person. And then how do you diagnose the plague? You do a gram standard culture of the lymph node or the sputum, or you can do a spinal tap and get it on the CSF. And usually when you stain them, you can see this safety pin. So if you look at that, it's called bipolar. So those little skinny little stains right there. They're darker on both ends, and those are kind of bipolar staining, and they have like a safety pin look. Not to say that there aren't other bacteria that can stain that way, but that's how usually it kind of looks like. But you know, do other immunoassays and lab studies to identify the plague. And how do you treat it? Antibiotics. Streptomycin usually is not commercially available anymore, so usually it's gentamicins. Gentamicin or doxine or Cipro. So if you recognize doxine, Cipro is also in there for the treatment of anthrax as well. you know, the plague is extremely contagious, and so how do you control this? So has anybody seen one of those N95 masks? Has anybody had to be fitted for one of those?
No.
So usually when you fit one, it's yours. Like you're supposed to always have it with you. But standard contact precautions. So anybody who is suspected or has the plague will be quarantined. But you also have to take care of yourself. You cover yourself with gloves, masks, gowns. They have to be in. So people who are that you think may have the plague have to be in quarantine for 48 hours. So until the results come back for cultures to make sure that they are not infectious. I didn't even know where my N95 mask was. I had it. It was in my car for the longest time. I was like, what's it going to do for me in my car? Okay. And the third one we're talking about is smallpox. Smallpox has been considered eradicated. The world's first eradicated disease back in 1980. So with this one, unlike anthrax and the plague, it's not a zoonotic disease. This is usually transferred person to person. So the smallpox is also known as the variola virus. It's a member of the orthopox virus, and it's a large DNA virus, and it's not as easily weaponized as anthrax because it requires more stability to grow in the environment, unlike spore kits.
They do still vaccinate military people.
Right, and I think you're talking about that at the end for the smallpox, or are you talking about for?
No, it says U.S. military stopped in 1985, but I know at least like a couple years ago they were still doing it.
Oh, really?
Yeah.
For anyone who deploys.
Okay.
Because I think there's some countries that have it as a weapon.
I know, which is kind of scary. Okay, well, I'll need to update my slides.
Maybe they buy it. I mean,
What?
Kathleen said maybe I wasn't supposed to tell you that.
What?
She said maybe it's a secret and I'm not supposed to tell people. They all have big scars on their shoulder though, so.
Really?
So I have a friend in the Air Force and she has the.
Yeah, they all have matching scars right here.
Huh. That's interesting. So with smallpox, you can have a prodromal disease. Again, it's a viral febrile illness. They have fever, sweats, headache, back pain, nausea, vomiting. Sounds like every other viral illness you can have. I think that's so. Incubation is usually 17 to 19 days. The mean days is 12. So usually it starts as a infection of the respiratory mucosa by the variola virus, and then the virus can get into the blood, and it can cause, with mild disease, you can get seeding of the liver and the spleen, and then with more viruses in the blood, you can develop more of the major viremia, and you get seeding in the skin. So these people will get the more characteristic rash of smallpox when you get the major viremia. And the rash in smallpox, the lesions all erupt at the same time. They start usually on the face and on the head and neck, and they move out to the arms, usually sparing the trunk. They have some, but it's not quite as much, so they call it centrifugally spreading from the head and neck out. But they will all be they all will look the same. Unlike chickenpox, they all have different stages of their rash. Same with what do you call it? Herpes zoster. So how does one present? So you can start with an anthem. So it's basically a rash on the inside of the mucous membrane, usually again like we talked about in the oral pharynx, in the mouth, tongue, and throat. And then you can develop the exanthem, usually about 2 days later. So we kind of already talked about the rash. And then after several days, the papules will become more vesicular in nature. And then they can change into large pustules. And then they can develop into scarring, crusting, and then they will develop into scars. So usually most people will have permanent pitted scars, so that's probably why they have it when they have the vaccination. They get these pitted scars from the smallpox. So in this one, you see a little bit of a minor rash in the child. See how more of it's on their face. This is like day 3 of the rash and onto the arms. You don't see so many, well, you don't really see a good picture of the chest at all, but you don't see as many there on that baby's chest. And so this is day 7. So see, it's more all over their face, on the arms. But if you look in the trunk there doesn't seem to be as many on the trunk. And then this is an adult with smallpox. So again, the rash is in its pustular phase. Again, look at all of them on his arms and his face, but it doesn't seem as much on his trunk. Again, they all look the same. They're big pustules, unlike the different ages and stages of chickenpox. So how would you manage someone who has been around a suspected smallpox contact? You would get them immediately vaccinated or give them a booster. And these people, you must quarantine them for 17 days. And then you can give them what's called a Vaccinia immunoglobulin. It's basically a Vaccinia anti-serum. So it creates passive immunity for that person. And again, the next slide we'll talk about what the actual vaccine is, vaccination for smallpox. So the smallpox vaccination, it employs the Vaccinia virus. So it's another member of the pox family, pox virus families, and it's used for vaccination. And so that's where the term vaccines came from, is from the Vaccinia. And it's related to the cowpox virus used to afford immunity to smallpox. So these people, when you give them in superficial layers, so punctures into the skin, the superficial layers of the skin. So although it initially was thought that vaccination against smallpox would afford lifelong immunity, it's found that immunity after single vaccination wanes after approximately 10 years. But there's also kinds of risk about whether or not you get vaccinated with smallpox, which you can, complications of being vaccinated with smallpox. So there's a couple of things. So normal host is someone who's normal, no being immunocompromised or anything like that. They can inadvertently inoculate themselves in the skin or the eye. They can get a generalized infection. You can develop erythema multiforme. You can get encephalitis. Pregnant women, if they can actually give it to the baby. And then those who have already like dermatoses, they can develop a rash from getting the vaccination. And then people who are immunocompromised can get tissue necrosis from getting the vaccination. And how do you treat it? There's really Cidovir is an antiviral that they've been using, but it's mainly supportive care. You can give them the immunoglobulin to help fight off the virus, and then strict quarantine for at least, again, 17 days until their scabs fall off. And again, it's an important public health emergency, so you must always let public health people know. And then Cidovir, don't know if you guys remember that, it's in your, I think it's in the aid section for the medications, but it's usually, it's being investigated as a treatment for smallpox because it acts against DNA viruses by inhibiting viral DNA replication. But it can be nephrotoxic and neutropenic. All right, and then this next set of ones we're going to talk about, they're called viral hemorrhagic fevers. So in this category falls the Ebola virus, the Marburg, yellow fever, dengue fever. That's kind of fall into this category. And so this is an RNA virus, causes high fever and generalized vascular damage. So these viruses like to attack blood and the blood vessels. So you can see the arm, the ischemic, and that way. So it's horrible. But humans' infections are caused by insect bites or contact with blood and bodily fluids. And the first one we'll talk about, so this is the, kind of already talked about that. So you can get it by inhalation, by fomites, or getting again body or bodily fluids. It's highly contagious, these are. But most human infections are typically due to contact with blood or body fluids of patients with this illness. So again, these people start with a viral infection, fever, chills, they can have weakness, it can evolve into shock and generalized hemorrhaging, so that's why the term viral hemorrhagic fever. They can get petechial hemorrhaging, they can become hypovolemic, they can have kidney dysfunction and liver dysfunction, and those with more in-organ damage have a poorer prognosis. And so the mortality varies between the strain of Ebola and then depending on how healthy the person was to begin with, if they have any significant comorbidities. So Ebola. Remember everyone started freaking out Ebola about, I don't know, 3 or 4 years ago. That's when I remember in our clinics, that was one of the things our nurses would have to ask them, have they traveled anywhere within the last, I don't remember, 30 days. And it was every time they came in, they had to ask it and they had to check off a box. And so, I mean, did y'all ever hear of Ebola before that? Anybody know about Ebola before that? I hadn't either. So I just put all these on here just so you got an idea of how far back it goes. But I remember that one, if y'all don't remember, that was a man that was from Liberia, and he had traveled to visit family in Texas. And so before he came, I guess he was helping some pregnant lady there in Liberia get to the hospital. And somewhere between then and there, he had contracted Ebola, and that's how he ended up in Texas visiting family. And then the 2 nurses that were treating him developed Ebola as well, but they survived. He ended up dying like a month later, I think, something like that. And at the same time, there was a physician that came back into the States in New York City. Remember that? And he was a doctor that works with the Doctors Without Borders. And he had contracted Ebola, but he survived as well. So, Ebola signs and symptoms. They can occur anywhere from 2 to 21 days after contact with the virus. Usually an average of 8 to 10 days. Again, they have that same viral illness, fever, chills, nausea, vomiting, diarrhea. So it's hard to distinguish this from, any other viral illness like the flu. Or even other tick-borne illness that I will talk about later, is like malaria, dengue fever. It's kind of hard to tell. So again, history is important for these patients, especially traveling, where they traveled to, where they came from. And how do you diagnose it? So basically looking at history, possible exposure. You can do I think it's a blood, PCR, real-time PCR testing for the Ebola virus. If you suspect someone has Ebola, they must be quarantined immediately, and public health authorities should be contacted. And then the public health department will then contact other people who were possibly exposed. So can you imagine that man coming from Liberia, and even the doctor that traveled from New York, how many people were possibly exposed from the time they left the airport? Not even the people at the airport in Liberia, then the United States, and then the cab ride, all of that. All of those people could have been exposed. Treatment, again, there's no true treatment. It's just supportive. These people, you give them oxygen, antipyretics, antiemetics. So for fever, you want to avoid NSAIDs or aspirin because of the risk of bleeding. For these people, you just use Tylenol. And there's no antiviral available to treat this. And then the Marburg hemorrhagic fever, again, a prodromal of illness, fever, illness in patients, but it's caused by a bacteria called Brucella that are found in fruit bats. And it's transmitted to people from fruit bats and spread among humans through human-to-human transmission. So it was first recognized in 1967 when a lethal epidemic of viral hemorrhagic fever occurred in Marburg, Germany. So among the laboratory workers exposed to the blood and tissues of African green monkeys that had been imported from Uganda. So secondary transmission to medical personnel and family members also occurred. In all 31 patients that were affected, 9 died. So occasionally they still have sporadic, isolated fatal cases among residents in Southeast Africa. How do you prevent these transmissions, secondary transmission? Again, these people have to be quarantined. And if you watch TV shows, they have what's called an anti-room, so it's a whole other room where you do all your gowning and get your gloves on. So these are strict areas for someone who has suspected Ebola. Because I can't remember, I don't think those nurses had much protection when they started treating that man. They probably thought he had the flu. So they probably didn't wear masks. Probably didn't, they probably had gloves on, but probably didn't wear gowns. So usually, they get it from respiratory droplets. So I don't know if he coughed on them. I can't remember exactly. Or did he? I thought he bled. I remember bleeding for some reason for him, but I could be totally wrong. So strict barrier precautions are key. They have their own toilets, body fluids are disinfected, disposable equipment, and then double bagging. A lot of I remember them talking about double bagging their tissue or blood, so you don't need that kind of stuff to get rid of it. And so usually diagnosis of viral hemorrhagic fevers based on usually clinical findings. So usually it's an outbreak, so you kind of look at your environment. Are there all these people getting sick at one time? What is the cause? But you can also do PCR and ELISAs to detect the disease and later diseases. No specific treatment, again, supportive care. Most of these people, like I said, are in the ICU. You all want to take a break, and we'll do dengue fever and malaria.